My name is Gail Armstrong, and I'm on faculty at University of Colorado Denver College of Nursing. I teach in our baccalaureate program and work with our pre-licensure students. One role that I have on faculty is that of med-surg coordinator, which means that I work with our faculty whose classes focus on adult acute care nursing. One of the most enjoyable parts of my work lately has been working with QSEN, Quality Safety Education for Nursing Initiative. University of Colorado was a Pilot 2 school for QSEN back in 2007, and I was one of the faculty members that helped integrate QSEN into our curriculum. This module focuses on early clinical education and how QSEN can contribute to your work as nursing faculty. I'd like to introduce Kathy Foss. Kathy Foss has a dual role with University of Colorado Denver College of Nursing and University of Colorado Hospital. And she works in both facilities as a clinical educator. Kathy, can you tell us more about those two roles that you have?
Sure, Gail. Again, my name is Kathy Foss, and I work at the University of Colorado Denver College of Nursing in the clinical development role through the Office of Clinical Affairs. My role primarily includes interacting with different clinical faculty in different clinical agencies, student placements, and then working with faculty related to clinical education. At University Hospital, I'm considered a clinical scholar, which is a particular model of delivery of clinical education, whereby I work with students directly in the clinical setting. I place students within the system at University Hospital for a range of probably 6 different clinical courses, and then mentor and facilitate clinical instruction, not only for students but for other clinical instructors at the hospital. Last year we placed 462 pre-licensed students at University Hospital for 6 different clinical courses from the University of Colorado College of Nursing.
Great. You know, Kathy, one of the areas that we haven't really changed much in the last 10 years is clinical education and nursing. How would you characterize the traditional approach in teaching pre-licensure students in the clinical setting?
The traditional approach, I kind of see it as on a wing and a prayer, or believe it or not. We push them into the room and kind of hope that they get it. And that's not to minimize the importance of having patient interaction for students, but what is it they're actually doing in that room, particularly when the instructor really can't be in every room with every student and every patient.
And the demands for new graduate clinicians have really changed, especially in the acute care setting. There's a stronger emphasis that students understand systems and that they have a systems perspective on quality and safety. How would you talk about some of the new demands on the new graduate clinicians as they move into independent practice?
I think one of the things that the clinical environment these days is particularly challenging, Gail, is related to the acuity levels of patients. Patients are sicker, their lengths of stay are shorter. The amount of time that students have to process information and understand what's going on in the clinical setting is much shorter. There's technology advances that students have to learn kind of on the job or in the moment that present challenges to them. There's expectations related to the role. The role of the registered nurse is very different than it was a number of years ago, particularly from a systems perspective, in managing different types of information, in managing and working with different types of people in different roles.
Right. I also think that being a participating member of the healthcare team, which includes multiple disciplines, is very important. And I think as, for example, the Institute of Medicine is tracking outcomes since '99, one of the most important pieces is how the nurse participates in that interprofessional team. Can you talk more about the expectations of the new grad?
I think one of the things that we need to look at related to pre-licensed students in their education, their clinical education, and looking at the research done with new graduates kind of rolls around communication and how the nursing student or the new graduate actually is able to communicate effectively within that team. Yeah. And how often do they have clinical experiences where they're working within that interdisciplinary team?
Absolutely. So how have you changed your clinical teaching in the last 3 or 4 years to better prepare our graduates for this increased complexity in practice, the increased demands, and the heavier emphasis on systems, Kathy?
I think one of the things is that we've done is to move experiences much earlier into clinical education that we've delayed prior to later courses. So in early clinical courses is bringing them into the acute care setting with a focused activity, primarily focused on being able to do a skill and also to be able to communicate with providers in the acute care setting related to what's going on with that patient as it pertains to that skill. That particular skill is simple as taking sets of vital signs, understanding what those vital signs mean, and being able to communicate those back to a provider and understanding what will happen when that information is passed through.
So traditionally we've had one student taking care of one patient. You called it kind of a wing and a prayer. We hope they get what they need. Can you talk more about this focused activity and how you structure it for maybe a fundamentals of nursing student?
Well, for a focused activity, it may be we have a skill that they're going to do. It could be an assessment piece based on a body systems, or it could be a skill piece. But they're seeing multiple patients related to that particular assessment or skill. So they have the opportunity to interact with patients and see the variations that they may encounter, even though the concept is the same.
So you'll work with a group of 6 students or 8 students? How large a group do you work with?
It will be up to 8 students. Typically, our average size is 6 in most of our rotations, but for fundamentals, it will be 8. We typically pair students because we also have found that the interaction between the two of them can be very supportive, and also they need to have some negotiation skills about who's going to do what, how are we going to communicate, how are we going to work together.
So you have a group of 6 students, and let's say you're focusing on pulmonary assessment, and what would a 4-hour experience for that group of students be on a med-surg floor?
Well, it may involve, actually it does involve listening to lungs on perhaps 18 different patients on a unit, and then going back and looking and doing some data mining. What are some of the respiratory parameters we might find instead of vital signs, what we might find in lab work if there's arterial blood gases done, and then also looking at medications that impact the respiratory system.
And what are you modeling for students, Kathy, when you work with them in this small group, kind of right activity at right time?
Basically, what we're modeling is the ability to use information to make clinical decisions.
Great, great. Well, it's a really new approach, and there are a variety of resources from QSEN that probably supplement this right activity at right time approach.
Right.
What's the feedback been from the students about this approach?
Feedback from students is basically it's a confidence builder. They enjoy having multiple interactions with patients. That doesn't mean that they don't desire to get to know one patient, but now they have a little bit broader range of practicing their skills, if you will.
And how about the feedback from the staff on the floor, where you're listening to maybe 18 patients' lung sounds? Are you in the way? Are you interrupting the work that has to happen on that unit? Or
Actually, no. And part of that is being able to communicate ahead of time to staff what it is that we're going to be doing during that clinical time so that they have a clear picture. We enlist staff to help us in delivering clinical education. So if they have a good understanding about what we're going to do, when we're going to do it, not only can they prepare the patient for us, but also it's a piece that we can then collaborate with them in our clinical findings.
Great. You've given us a really good idea of some shifts you've made in your own teaching. So thanks for your time, Kathy.
Thanks.